Good morning. So I would like to start this panel discussion this morning, mental well-being, disability, and development. So it is my great pleasure to welcome all of you to today's panel. The panel is co-organized by UN DESA, Permanent Mission of Bangladesh, and El Salvador, Permanent Mission of El Salvador to the United Nations, NGO Committee of Mental Health, United Nations University, International Institute for Global Health in Malaysia, and the World Bank Development Learning Center in Tokyo. On September 23rd, as we heard many times earlier this morning, there was a high-level meeting on disability development that was convened by the General Assembly. And it was a historic first-ever event, as was repeatedly mentioned by speakers this morning. And this meeting adopted this landmark document to guide efforts toward disability inclusion in a global development agenda through 2015 and beyond. And the outcome document is available, by the way, on our website, www.un.org/disabilities. But this actually emphasizes, as you could perhaps take a look at this outcome document on our website, but you could also have an accessible version. If anyone wishes to have accessible version, we have them available here, so please let us know. But this outcome document is a vision, and also it's a list for which we need to move forward for disability inclusion in development framework. And in this context, we are looking at persons with mental and intellectual disabilities, which constitute one of the most disadvantaged and marginalized groups of the population. And to date, we discussed invisibility of disability and persons with disabilities in MDGs, but to date, persons with mental and intellectual disabilities and psychosocial disabilities remain also invisible in mainstream development processes. And as you know, the economic and social health impact of poor mental well-being is very pervasive and far-reaching. We learn that in our everyday life, this could lead to poverty, high unemployment rates, poor educational health outcomes. Again, I make a reference to this morning's opening because it was very powerful. All of our permanent representatives, our representative of civil society was saying that now it is a time to translate our commitment into action. And so, which actually requires us to look into not just the commitment itself, and in saying inclusive development, including persons with mental and developmental disabilities, including those with psychosocial disabilities. But we need to find a way for us to incorporate their perspective and their situation into the work we do to build a new global development framework. Having said that, let me just introduce you to a few things that we have been doing during the past 5 years. And we've been working closely with WHO, we've been closely working with World Bank in order for us to address this issue, because we tend to have a number of disability issues, but we also are quite aware that this area, mental well-being and disability development, it's not getting enough attention even at this time. And in this context, we actually co-organized the launch with the WHO report on mental health and development in targeting people with mental health conditions as a vulnerable group at the UN in New York in 2010. And prior to this, what we did was we wanted to see how best we can bring together the experience of WHO and other stakeholders and DESA as a center, which is like a coordinating body also for many of the development activities at the United Nations, to see, to build like a conceptual framework on mental disability, mental health, mental well-being, disability development, because we are looking at the impact of mental disability on development, but also we are looking at the impact of mental disability in a context of again, persons with well-being of persons with disabilities, because we all need mental health, and then, but in this context, persons with disabilities are not able to get sufficient services, for example. So we are looking at disabling impact of mental health on development, but we're also looking at disabling impact of mental disabilities, psychosocial, different types of mental problems concerning mental well-being on persons with disabilities, and the impact on development. So we are looking at these different dimensions and developed the concept paper, which is a landmark policy analysis of DESA WHO policy analysis on mental health and development. This is available on our website. And DESA and WHO also organized, based on this policy paper, a high-level panel event entitled An Emerging Development Issue, Integrating Mental Health into Efforts to Realize Millennium Development Goals and Beyond. So this was also highly appreciated by the international community at the time, because it was still a new issue. But now I think it's becoming more and more a central issue when we discuss mental well-being and disability development. And I will not go into discuss more details, because now we have the world global experts, but we organized with WHO and UNU, and also, again, government of Malaysia, and many other stakeholders to go into specific recommendations. So we organized the expert group meeting earlier in May this year. So this actually, a panel discussion would also have in front of this panel discussion this expertise and concrete recommendation which was generated by this expert group meeting. And we are very grateful in this regard to Dr. Tsutsumi from United Nations University, who will share with us the recommendations, and Dr. Izutsu, who was the main brain behind this panel, this expert group meeting, to be able to also guide us in our discussion this morning. We just want to also mention that we've been privileged to work with leading countries like El Salvador and Bangladesh to bring this issue to the fore of the work of our department. We also, as you may know, Qatar, Brazil, and other member states also took initiatives, and you see a lot of initiatives now at the global level. For example, like through implementing the commitment to World Autism Day, and also many other activities concerning developmental disabilities. Now I would like to give the floor to the moderator of the panel this morning, Dr. Izutsu. Dr. Takashi Izutsu is a Senior Knowledge Management Officer from Tokyo Development Learning Center Development Effectiveness Unit, East Asia and Pacific region. And he has an extensive experience in mental health issues, also authority in autism, issues concerning autism, and has extensively worked in developing countries, both developed and developing countries. So the floor is yours, and welcome.
Thank you, Ms. Ito. Ladies and gentlemen, welcome to the panel discussion on mental well-being, disability, and development to mark the International Day of Persons with Disabilities 2013. This panel discussion will focus on one of the most neglected but very important emerging priority in development, mental well-being and disability. As Ms. Ito mentioned, UNU and the UN organized the UN Expert Group meeting on mental well-being and disability and development earlier this year in Malaysia and shed light on this key emerging issue. In this panel discussion, we would like to discuss the outcome of the expert group meeting in conjunction with the outcome of the historic high-level meeting on disability and development held in September, and strategize how to realize integration of mental well-being and disability in development discourse, including post-2015 development agenda. Today, we have 5 distinguished panelists from the member states and UN and civil society. Since we are a little bit behind, without further ado, I would like to invite our first panelist, Dr. Judy Bass. Dr. Bass is Associate Professor at the Johns Hopkins Bloomberg School of Public Health, Department of Mental Health. She's a mental health epidemiologist with a background in economic development. Her works include maternal mental well-being, its impact on children, and mental well-being of sexual violence survivors. Dr. Bass, you have the floor.
Thank you. Thank you, everybody, and welcome. Thank you for staying in this from that great performance that we had as we move to something that unfortunately is a little less humorous. We have but I think just as important as the topics that have already been discussed. So one of the issues when we think about mental health is that it is prevalent. It is pervasive. Every country, every continent deals with the issue of mental health. And this first slide shows you some of the data that we can get from the WHO Initiative World Mental Health Surveys. It's a lot of data, so I'm not going to necessarily go through this slide, but I wanted to show you that we can get a range, focusing in specifically on the final column, which is the prevalence or the rates of disorder of any of the different disorders. We can see that mental health problems do not discriminate between high, low, and middle-income countries. That the rates of disorder, lifetime disorder, exist in all of these contexts, in all of these places, and as was said before, affect our families, our friends, our neighbors, and the people we work with. Now, we want populations, and all of us, to have health and well-being, and that's an important part of life. But part of the reason that mental health is so important, and sadly lower on the development agenda, is that it not only affects the health and well-being, but it also affects ability, functions, and ability to engage in a wide range of components of daily living. And that's most evident in the measurement that's been used called the DALYs, the Disability Adjusted Life Years measure. And what this measure is it's a mechanism by which the WHO and others can compare different types of illnesses, different types of disorders, different types of conditions on a metric that allows them to say which type of problems have different types of impact on ability, on disability adjusted, years living with disability, which is a product of both the time at which a disorder happens, as well as the length of time with which people live with that mental health condition or the other types of conditions that are up here, as well as the severity and the impact of that condition, that disorder on the abilities of tasks of daily living primarily. And so if we look at what's often considered the most productive years of life, hopefully these aren't the only productive years of life, but these are the most productive years of life, ages 15 to 49, we see that within the range of a wide range of health conditions globally, that mental health disorders, mental health problems, these are the top 15 disorders. Mental health problems show up in 4 of the disorders specifically, and that mental health problems also probably show up in many of the other ones. So interpersonal violence has both physical as well as mental health impacts. And so this is globally, low income, middle income, and high income all combined. If we move to low and middle income contexts, we're needing a population that is functioning, becomes an even more important component of being able to have political and economic development. We see that mental health problems become an even bigger part of the equation. So looking specifically at low and middle income countries, again in the same age range, we see for men that the mental health problems still show up in the top 15, and that for women, particularly moving up to the major depressive disorder, it's the second most disabling illness, condition, disorder for all women in low and middle income countries in this age group. Now, why is that important? So here's an example of what this actually means beyond the data. If we look at maternal mental health, so thinking about early years of fertility, we start with the 15 to 24-year-olds, which is, in many contexts, the early years of fertility. Major depressive disorder is the most burdensome disorder. If you go through that list, it's the #1 in that age range, globally, not just in low and middle income countries. If you go through the range to 44, so the range of general fertility period, it's the second most burdensome. Why is this important? Well, it's important because it affects women in many ways. It affects their economic functioning, their ability, both because of the disorder itself, the symptoms, the presentation, it can affect their ability to function in a workplace, to get jobs, things like that, income. It affects their social functioning. It can have problems around isolation, reduced social networking. And it also has an impact on their maternal functioning, which means that it doesn't only impact themselves, but that there's a transgenerational impact. So research is showing more and more that maternal depression affects the infant in utero. It affects the child postpartum and through development. And what are the types of outcomes that have been shown to be affected by maternal depression? Things like poor physical growth of the infant, increased rates of illnesses, increased risk for neurocognitive delays, as well as lower academic achievement, as well as increased rates of behavioral problems. So starting early in life, these children, not all children, of course, there's just an increased risk, but they're at increased risk for starting off hitting many of the milestones that would delay them in having a wide range of being able to function in the world in which we live today. And so one of the things that's really important with mental health services is, given that we know maternal mental health is such a burden and such an important problem, is integrating maternal mental health services into mother and child, maternal and child health services. But there's been it's been quite slow, that integration process. But mental health isn't just about tasks of daily living. Mental health in terms of development also has an economic impact, economic functioning, economic impairment. So according to the WHO, an overwhelming majority of people with mental and psychosocial disabilities are living in poverty, have poor physical health, and are subject to human rights violations. Now, what do we know about the association between mental health problems, particularly common mental health problems, and poverty? Well, much of the research has shown that these things that people who live in poverty have more mental health problems. But the research is also showing that people with mental health problems have higher risks of moving into poverty, have more risk for being unemployed, have experienced more financial stress. So it's both directions that we're talking about. So when we talk about integration and economic functioning, mental health plays a key role both in the populations who are marginalized and not included in our economics, as well as populations who may fall out of our economic programs. So that the association between mental health and poverty, linking these two, strengthens the case for inclusion in the development agenda and meeting the Millennium Development Goals. So lest you think that these are all the problems and there's very little solutions, I wanted to give a brief example of where there is still hope and where processes and programs might be helpful. So the example is from among sexual violence survivors in the Democratic Republic of Congo, a place with lots of war, lots of poverty, lots of logistical challenges. This is specifically in Eastern Congo, low levels of education, and that women who are sexual violence survivors experience the dual burden of poverty and trauma. So mental health problems and often economic and social exclusion. So there's that strong link between all three of those issues: trauma, symptoms, exclusion. Recently, we completed an intervention study with international and local NGOs and local community-based organizations. And through working collaboratively in the region with local staff, we were able to implement mental health interventions that improve the mental well-being of women who are sexual violence survivors with high levels of trauma symptoms. And not only did it have an improvement on their mental health, but there were also some subsequent improvements in their economic livelihoods in terms of the number of hours worked per week when compared to a control condition. So here's a situation where a mental health intervention that was feasible and could be implemented, and we saw a wide range of outcome benefits, not just mental health benefits. Concurrent to that, we did an evaluation of a social economic intervention because we talked about that dual burden. That social economic intervention also had smaller mental health effects, but it has some mental health effects, but it also had more economic effects. So the reason to bring this up is that these interventions were able to be implemented in this context and to concurrently impact the dual burden of economic functioning, of exclusion, as well as meeting the mental health needs of the population. So with that, I wanted to have the opportunity to lay out some of the issues and lay out the land around the burden of mental disorders globally, as well as give some examples and some hope for where services, even in the most complex situations with few resources, can still be implemented. Thank you.
Thank you, Dr. Bass. Thank you very much for the comprehensive overview of the current global mental health and also showing the close link between the development priorities and mental health conditions. As the example showed, the mental well-being affects gender equality issue, MDG3, and maternal mental health affects maternal health condition, MDG5, and also child health condition, MDG4. So it is a great opening to shed light on this kind of link between development and mental well-being issue. Then I would like to invite Dr. Atsuro Tsutsumi, the coordinator on mental health and non-communicable disease program at the United Nations University International Institute for Global Health, UNU-IIGH. UNU is a think tank of the UN within the UN, and Dr. Tsutsumi is the person who organized the expert group meeting together with Ms. Ito in DESA, the UN, and we are happy to have you here. The floor is yours, Dr. Tsutsumi.
Thank you very much, Dr. Izutsu. I'm very grateful to have this opportunity to talk about the outcome of the UN expert group meeting on mental well-being, disability, and development. First of all, I'd like to share the basic facts on mental well-being and disabilities. Globally, 1 out of 4 people will experience some sort of the mental health condition in their life. Annually, 1 million people die due to the suicide. The suicide is the second leading cause of death among adolescents. In particular, the first leading cause of death for young girls. At the primary healthcare settings, 1 out of 5 people have mental disorder. 80% of the people with serious mental disorders do not receive any appropriate treatment in developing countries. Economic impact is also vast. It is estimated to be $16.3 trillion between 2011 to 2030. This is a figure to show the comparison between the number of the deaths between the suicide and violence. As I mentioned, the number of the deaths due to suicide is 1 million. This number is higher than the number of the deaths related to war and murder combined. Persons with mental or intellectual disabilities tend to face discrimination and severe human rights violation. In particular, in disaster settings, the persons with mental or intellectual disabilities tend to be left behind, while mental aspects play crucial roles in recovery. However, extremely limited human and financial resources are allocated to this area of mental well-being and disability. And there is a limited policy and programs worldwide. To address this issue, we organized UN expert group meeting on mental well-being, disability, and development in Kuala Lumpur early this year. This is the first UN expert group meeting focusing on mental well-being. This is also a part of the process leading to the UN high-level meeting on disability and development in September this year. This is a photo of the outcome document. I think you have it. Yeah. Yeah, I hope you can read it later. Thank you. The expert group made two key recommendations. One is to integrate mental well-being into all social development efforts as a key indicator for sustainable development. And the second one is to strengthen the protection and the promotion of the rights of the persons with mental or intellectual disabilities as a key priority in disability discourse. The expert group recommended also several key action points as follows. This is for the priority areas. As to the poverty reductions, we need to recognize and invest in mental well-being as a contributing factors and consequences of the poverty. Regarding sustainable development, it is also needed to integrate mental well-being as a key indicator. As to inequality and accessibility, it would be required to ensure the rights of the persons with mental or intellectual disabilities are included and their access and opportunities are equalized. As for the disaster and the conflict, it would be needed to include mental well-being and disability perspectives in disaster risk management and efforts related to the peace and security. The way forward, we need to integrate mental well-being disability into post-2015 development agenda as a cross-cutting priority, since human beings are emotional beings. It is also needed to ensure mental or intellectual disabilities are included in the disability policies and programs. It would be helpful to develop a periodic reporting system on mental well-being in the United Nations systems. It would be also helpful to consider the establishment of a UN interagency mechanism on mental well-being. Thank you very much. I hope we are looking forward to working with you on this issue. Thank you very much.
Thank you, Dr. Tsutsumi. First of all, I'd like to congratulate you and UNU and DESA for having this first ever expert group meeting focusing on mental well-being and also mental and intellectual disabilities. And also it is really encouraging to hear that the expert group recommended to consider integrating mental well-being and disability as a cross-cutting issue of the post-2015 development agenda. Thank you very much again. The next speaker is His Excellency Mr. Ruben Armando Escalante, the Deputy Permanent Representative of El Salvador to the UN. You have the floor. Thank you.
Thank you so much to DESA for the invitation. My name is Ruben. I can see a lot of my colleagues from the third committee here, so I'll try to be really careful about what I say. And I know the time is running, so what I would like to do is, I have a few, actually have a lot of talking points, but I'll try to squeeze my my presentation into providing some inputs and some ideas, and also challenging a little bit of how we within the UN system can do some follow-up, because we are not, in my case, I am not an expert. So that came from Dr. Bass, who gave all the numbers, and also we have all the other inputs that are coming from the UNU in Tokyo. So I thought it would be helpful for us to think also about how to actually do the follow-up in the intergovernmental process that we are leading here at the UN. As you know, I'm also sitting here, and I would like to acknowledge the presence of my Bangladeshi colleague. We are both sitting at the bureau of the Conference of State Parties to the Convention on the Rights of Persons with Disabilities, and we are just halfway through. We still have another COP coming up next year, and I'm sure that those discussions will also be fruitful to move this agenda forward. One of the things that I think we need to talk about is to make a difference between those persons who actually have something that may be categorized as a mental or intellectual disability that might fall within the scope of the convention, and then we can talk about the procedural follow-up to the convention itself, and those other issues pertaining to mental health and well-being that don't necessarily follow within the scope of the convention itself. Some of the issues, if I can start with that, and I think it's really been expressed here, the issue of how the environment affects your mental well-being. As you know, in the case of my country, El Salvador, and this is something that's also being expressed by my PR in some other events that have been organized by the NGO Committee on Mental Health, you have to look at the different stages through which a society has been going through. In our country would be the 12 years of civil war, and right now the situation of social violence, in which the perception of violence and situations in which you are forced to be afraid of your surroundings can actually affect your mental health and your mental well-being. And that's a collective burden that a lot of societies, including my own, have to continue sharing. It's really interesting to me, though, to kind of realize that when you have a look at the different data from El Salvador when it comes to violence, the number of violent deaths will be really high, whereas the number of suicides might be really low, which cannot be the case in other societies that might be considered safe, but in which the rate of suicide might be going really, really high. And that also, in my personal opinion, has a lot to do with your mental well-being. I myself was a very troubled adolescent. I had a lot of periods in which I had suicidal thoughts, and the only reason why I didn't commit suicide was basically out of love to my family, because I know that the burden and the stigma will keep with my parents even after I died. So the cohesion of the family and the cohesion of society is also a factor that you also need to be taking into account when you talk about general well-being in the case of mental health. But now, if I would like to narrow down a little bit my remarks to what falls within the scope of the convention itself. Can you hear me if I sit back a little bit more? Yeah, because I need to be looking at my iPad to know also. When we talk about the institutional arrangements that we have here at the UN, I'm sure that you all agree that we have all the conventions that apply equally to everybody. We have the elaborations of the human right to the highest attainable standard of mental and physical health. And we even have the rapporteur in Geneva who's actually tasked with trying to provide inputs to all the member states. However, I do believe that even within the convention and even within all the follow-up that states do with all the process of reporting, we don't really pay as much attention to mental disability the way we do to other forms of disability, because they are not that obvious, and because compared to other forms of disability, it's actually more challenging to deal with. If you're talking about physical disability, it narrows to participation and accessibility. when you're talking about intellectual and mental disability, it brings another layer of public policy that may involve another kind of investments, that may involve another kind of training and political decisions that you're not ready to take yet. So that's like another step that I believe systematically, as member states, as the system, we should be able to look into. And we have other inputs as well. I remember the World Health Organization last year, they launched this quality rights toolkit on mental health. It was sometime last year. And I remember it was the first time that it actually, the launch was in a hotel. I think it was the UN, what do you call the building? One? The Millennium Hotel? Okay. And I was sitting in the back, and I was just basically crying, tears streaming down my face because of the videos that they were showing on the way in which the human rights of people who suffer from mental disability are being systematically violated within the facilities that are being run by the state. So you have there another layer of how the state should be paying more attention to this kind of violations of the human rights under the CRPD and any other convention that are happening in this specific group of what you can consider persons with disabilities. Some things that we have been, before I talk about the case of my country a little bit, I did a little bit of research. And even though I absolutely believe that all of the CRPD also pertain to persons with mental disability as well, it was really striking to see that the word mental only appears 1, 2, 3, 4 times in the convention. And the dimensions to the word mental don't even relate to mental disability, but mental well-being itself. So you have it in Article 1, which is the purpose of the convention, in Article 17, which is protecting the integrity of the person, Article 24C, which is education, and Article 26, which is habilitation and rehabilitation. So there you see that we still need to keep working on this specific issue that relates to disability. Then we had the high-level meeting this September that should also be incorporating some other elements to look at it not only from a human rights, but also from a development and a development mainstreaming perspective. But in the case of what we are doing, if I can talk to you about the Salvadoran efforts in a nutshell, we, in the case of mental well-being, there are still a lot of gaps. There have been some movements in terms of political will. They are thinking about the lifting of the reservations that we put on the convention at the moment of ratification, and also some internal legislation that has been modified. Before, for example, family law and electoral law will be discriminated against persons with disabilities. And for example, the blind, those who are deaf, and those who are, and in Spanish they have this very, very stigmatizing expression that's, it's enajenados mentales. It basically means mentally crippled. It's a very, it's not the best word that you would like to use. We are moving towards trying to amend those legislations. Up until now, all references to the blind and the deaf have been removed. So now they can exercise their political and civil rights to, like voting and access to political parties. But still, that reference to mentally crippled remains. In family law, for example, there were some restrictions on persons with disabilities from being able to be married, because marriage is supposed to be done only with the full consent of the parties, and then the state takes it upon itself to actually decide who has the full consent. And when it comes to persons who are regarded as having a mental or intellectual disability, then the state kind of acknowledges that those persons are not able to decide by themselves whether they want to be in a relationship or in a marriage or not. So even though still process needs to be done, at least the political will and the legal amendment that needs to be done to pave the way is moving steadily. Even though one of the things that I believe we all have to take out of this room is that we need, when it comes to mental disability, we need to move from a paradigm of substitution of decisions to a paradigm that helps the persons with a mental disability to make decisions of their own. So everything that we do within our public policies that takes away the decision-making process of the individual needs to be corrected in a way. Now, how we can be doing that within these walls of the UN? Some ideas that I would like to leave with you, as some of them might be challenging, is to bring those issues to the political headquarters here at the UN. Even though I totally understand that we have the Human Rights Council in Geneva and the World Health Organization in Geneva and the UN in Tokyo, it's here that we make the political decisions. And it's happened before with HIV and AIDS in 2011. It's happened before with non-communicable diseases as well in 2011. So it's a follow-up that maybe we here at the political level should be willing to have a look into. The other one is the committee itself in Geneva. I know they are terribly busy right now preparing the first 2 general comments. I think one is on accessibility and the other one is on something else. But maybe a future general comment on how the convention applies in the case of persons with mental disability can be really helpful and a helpful tool for states to actually implement those. I was having a look, and I'll be finishing 1 minute, sir. I was having a look before coming here to the report. We just defended our first report to the committee in Geneva this September. And I was having a look at the list of issues prior to reporting that the committee uses. And there were really, really few references to mental disability in the questions that were being asked by the committee itself and that the state was responding to. So also encouraging the committee to include mental disability and intellectual disability in the whole process of reporting has a domino effect. That's an internal thing, but it makes a domino effect of actually making the state think about the issues and having to come up with answers and having to come up with public policies to respond to the answers that are being asked by the committee. So those are 2 things, plus the Conference of the State Parties. I don't want to make any commitments here because I'm the only one from the bureaus, and I don't want to put my Bangladeshi colleague in an awkward position. But also the Conference of the State Parties should be able to address these issues. Since we choose themes every year, and as you know, the Conference of the State Parties of the CRPD is by far the most, active in terms of analysis and in terms of actually looking into the implementation of the convention by the states themselves. So I left these 3 ideas with you that pertain to the committee, to the process of reporting, to the COP, and to bringing the issue at the political level here at headquarters in New York. And with that, I will shut up. Thank you very much for your attention.
Thank you very much for the very, very inspiring presentation with a new perspective, practical perspective, how to make it happen, how to especially make it happen at the political decision-making level, at the global level, and also how to make this happen in country level. And also, thank you for pointing out some key issues like the importance of social support to promote mental well-being, and also the importance of the role of mental well-being in relation to violence. Okay. Now, I would like to invite His Excellency Mustafizur Rahman, the Deputy Representative of Bangladesh to the UN. Thank you very much for coming, and the floor is yours.
Thank you, Mr. Moderator. Distinguished delegates, ladies and gentlemen, first of all, let me also thank UN DESA to take this initiative, and we are happy to join in this endeavor, and special thanks to Akiko and your team. The presentations made thus far have been quite enlightening, and it is indeed a privilege for me to join this very rich and learned panel. I'm not an expert on this issue. As you all know, as diplomat, we have to be generalist. But in my past life, I had some experience being a physician for some time. I lost most of my knowledge, but I and I try to hide this this aspect of my past life. So I think the selection of this topic has been very timely and appropriate. For that, the UN DESA deserve a special thanks. As the statistics revealed by Dr. Bass on the prevalence of persons suffering from mental disability is quite astonishing, if I may put it like that. Also, the UN, the WHO report gave a very grim picture. If I pick up some of the information referred to in this concept note, that 1 in 4 people experience a mental health condition in their lifetime. And it is also alarming to learn that about 1 million people die worldwide due to suicide. This has been discussed also by our colleague from UN University. So, and even worse, 85% of people in low and middle income countries suffer from this disorder and receive no treatment, particularly coming from the low and middle income countries. So without mainstreaming this aspect, mainstreaming the concerns of such a huge population, we cannot think about achieving a sustainable or inclusive development that we all aspire. Yet this issue has never been got eminence in global discourse, but particularly in the UN. Against this backdrop, I would like to mention a couple of reasons that cause the exclusion of persons with mental disorder from the society. First is misconception and social stigma. This has been also referred to by Dr. Judy Bass. In many parts of the world, such persons are viewed as persons possessed by supernatural evil power and considered as violent and kept in chain or locked in dark rooms. They suffer from neglect and mistreatment. When society recognizes the need for treatment for persons with other diseases like cancer, diabetes, unfortunately, they're not ready to accept mental disorder, mental problem as equally important. When it is considered that mental health condition is untreatable, even the family members do not want to talk about it. They try to hide this and leave mental disordered persons in shadows, further aggravating or exacerbating their precarious conditions. Due to the same stigma attached, children with mental disorder are often denied access to education and rejected by other peers. As they do not have education, people with mental health condition fail to access job market, and which ultimately drives them to poverty. This has been very eloquently argued by Dr. Bass. And due to poverty, many have no means to pay for needed treatment and thus remain entangled in a vicious cycle of poverty. Moreover, in many countries, mental health issues are overlooked from the development process, strategies and plans. Here I thought I'd share some of the positive developments that took place in my country in this area. However, due to time constraint, I would skip those and just to say that learning from our national experience, we tabled a resolution on autism spectrum disorder last year in the UN. We are happy to share with you that the resolution, first time in the UN, received overwhelming support, the large number of co-sponsors, and adopted by consensus. This is the beginning. I think a lot remains to be done to bring all of them into the development endeavors within the UN and outside, nationally, internationally, by the governments, by international organizations, as well as civil society. I would like to emphasize the 3 points here. First of all, we need change in the attitude towards mental disorder through awareness raising. This is the most important thing for the society to develop disability inclusive policy. Second, adopt policies and programs sensitive to mental disorder. There is no denial that mental well-being is linked to a range of development outcomes. A professor from Dhaka, and UN University has highlighted those. These include better health status, higher educational endeavors, enhanced productivity and earnings. Absence of these basic components leaves a person in despair and ultimately leads to his or her psychological disorder. Therefore, there is an urgent need to adopt policies targeting to the mental disorders. This is capital-intensive endeavor. So while it is the responsibility of the national governments to adopt such programs for the persons with mental disorders, development partners should also extend the helping hand, especially to LDCs, for implementation of such policies. We in Bangladesh have been benefited from such support, and the same gesture should be extended to others in need. Third, and I think this is very pertinent and does not involve money as such, it is the role of family as a primary caregiver to the persons with mental disability. Research has found that people living in the traditional family structure are less likely to suffer from mental disorders than people living outside such structure. It is in a traditional structure, family members support each other in crisis, emotionally and financially, share burden, thus relieve them of mental pressure. My good friend Sebastian from El Salvador has referred to this, and he related this with his own life, and how important this has been for him. Indeed, a congenial family and environment also helps in shaping brain development of the children. Family interventions in treatment of persons with mental disorder have proved to be cost-effective in countries where hospitalization and professional care are inadequate and expensive. Therefore, I would emphasize that the traditional structure of family needs to be preserved and strengthened. These are a few thoughts I thought I should share with you, especially in today's event, and since we are celebrating or observing the special occasion today. Hope this were useful and relevant and help move our common endeavor of pursuing the issue of disability within the UN and outside. Thank you so much for your patience.
Thank you very much for the strong message to shed light on the importance of awareness raising to fight stigma, and also to highlight the key link between mental well-being and development issues, and also the importance of the partnership and collaboration among development partners to make mental well-being integrated into those priority areas. And congratulations for the adoption of the resolution on autism, and it's as highlighted, it is really historic and it is a starting point, and I think many people who are coming in the future can utilize this resolution as a starting point, and I think this is wonderful. And also the representative of Bangladesh mentioned the important but neglected issues such as the primary caregivers issue and family issue, and also access to education of children with disabilities, children with mental or intellectual disabilities. Thank you very much. Last but not least, I'd like to welcome Dr. Paul Bolton. Dr. Bolton is an associate scientist at the Applied Mental Health Research Group, Center for Refugee and Disaster Response, Johns Hopkins Bloomberg School of Public Health. And Dr. Bolton is an expert on cross-cultural assessment of mental health and functioning. The floor is yours. Thank you very much.
Thank you. Thanks, Mr. Moderator, and to my colleagues on the in this group. I just like to use the hand mic because sometimes I like to stand up and wander around. So if I do that in the next 5 minutes, please forgive me. In coming last, I knew that we were going to hear a lot about the problems involved in with mental health, and so perhaps now I can be the person who, along with my penultimate colleague, injects some hope. So I want to talk a little bit about some promising work we've done on addressing disability related to mental health. One of the reasons why mental health problems have such a pervasive effect on in terms of disability is that they affect not only physical function, but also mental function, emotional function, social function, and also behavior. And when I talk about behavior, I mean maladaptive behaviors. For example, when people abuse alcohol, that's a maladaptive behavior, which we also see as an aspect of disability. I wish I did have the slides, because I've got a couple of results to show, but apparently it doesn't work. Okay. One way to think about disability too is to think about it in terms of people's ability to fulfill their roles in society. Roles with respect to themselves, with respect to their family, and with respect to the wider community. So in our work as researchers, when we think about disability and assess it, we start with actually thinking about disability in terms of people's ability to do the things that they need to do. So what we do is we go out to communities all around the world, and we ask men and women, what are the things that you need to do to take care of yourselves, your families, and your community? And then whatever people tell us, we then use that to create instruments which we then use to assess their level of disability. And if we had a slide up here on the different responses, we get it be interesting, because my wife always likes this slide. On the left side, it has the responses, typical responses from men, which are usually things like earn money, head the family, make decisions, things like that, usually 4 or 5 things. And on the right-hand side, there's usually like 15 things from the women. And they usually, and they can go on forever. And we find that to be actually pretty consistent across cultures. So we assess disability, and then our business is to actually go out into communities and find feasible mental health interventions. And then we take those interventions and we assess their impact on disability. So we assess people before the, that's the slide on, yeah, okay. That's the slide on different activities that men and women do. And actually the list on the right could go a lot longer. I'll go past that. I'm just going to skip a few slides to save time. So we also assess mental health symptoms when we look at interventions, and now I'll stand up. So at baseline, we often find this is actually level of depression on the left side, so higher is worse. Here is trauma symptoms, higher is worse, and then female and male function, and actually higher is worse on those two as well. So this is I'm just offering this as a typical example of a study that we do. So we were assessing an intervention, and we assessed people at baseline. We gave them the intervention, and now one line here is the control, which is up here, which shows that people do show some improvement over time, and we do find that normally for both mental health and function. The other line, which has the steeper curve in each case, is actually a psychotherapeutic intervention, one of several that we try. And the point of the slide is to demonstrate that not only as mental health improves, function also improves significantly, or in other words, disability decreases. Another way to look at impact is in terms of effect sizes. An effect size refers to how big does an impact does something have compared to a control group who didn't get it. And normally we find we interpret effect sizes of 0.5 as moderate, and anything over 0.8 is large. So here we have, these are all studies from different parts of Iraq where we tested several different interventions. And for almost all of them, you can see that we had a moderate to large effect size. We haven't actually published these results yet, but these are similar to other results that we get in other sites. So the point here is that here we have a cause of disability which is very addressable and which we can really do something about. Next. I want to talk a few minutes about one of the more promising types of intervention, one of the ones that was on the previous slide. We have found in our work in the last 10 years or so that we can take psychotherapeutic interventions that normally are the realm of psychiatrists and psychologists, and we can train local people who don't have a previous mental health background, may not have even a clinical background. We can train them and monitor their provision of the intervention. And we can train them in a single approach that enables them to treat multiple mental health problems at once. And this is critical, because what we find normally is that most people in the world don't just have depression. They don't just have anxiety. They don't just have PTSD. Frankly, the more common state, particularly in lower income countries and places affected by violence, is they have all three. That's the more common thing. You either have none or you have all three of them at once. So we need interventions that can treat all three at once. Next slide. So this is that intervention. And this slide just illustrates some of the different elements or activities in that. So I know this might seem strange, but when you look at the technical names of some of these interventions, how could a local worker actually learn to provide that? And I don't have time to go in today to say that how they can, but the answer is yes, they can. I guess now I feel like Barack Obama, right? Yes, yes, they can. Okay, next. Now, WHO has the MHGAP program. The idea is to provide evidence-based treatments with good scientific evidence to people around the world. But we have a bit of a problem with MHGAP, and the problem with MHGAP is that the current plan is that if you need real mental health treatment, you have to get referred. And the problem with getting referred is often there's no place to referrals to be sent. Often you go to the referral site and they don't have any more good treatment than where they're getting referred from. The third is these people have mental illness. It took a big effort on their part and the family's part just to get them to the clinical center due to issues of stigma and due to issues of cost, and now you're going to send them somewhere else. And we know from experience that 90% of those won't make it. They won't go to the referral site. Next. So an intervention like the CETA or any of the psychotherapeutic interventions that can be provided by a local person, if we can provide these interventions at the local level from local workers, we can actually do a lot about the disability that is due to mental health problems. Next. So the overview of the presentation, I'm winding up now. A lot of people, most people have multiple mental health problems if they have any in challenging circumstances or situations of violence. Okay? Mental health affects all aspects of functioning, not just physical. We can address them and we can restore, largely restore people to function. I don't mean completely, of course, but we can take a significant chunk out of the disability that's affecting many people in the world. That's it. Thanks very much.
Thank you very much, Dr. Bolton, for looking at the hopeful aspect and also looking into many different, faces of the issue. Like many people have multiple conditions, and there are many countries which do not have those referral destinations, so that people might not be able to address the condition, and so on. And thank you very much for that. Due to the time constraints, it seems we need to close the panel discussion. It's already 1:20. But I think this is a wonderful starting point for collaboration and discussion for the future. As far as we know, we didn't have this kind of opportunity. I mean, we had some limited number of opportunities like this, but it is really encouraging to see this happening in the UN headquarters in New York, and if we can continue communicating with each other, and probably to form a community of practice and to utilize many different opportunities like COP of CRPD and also DESA Forum and so on, to continue communicating and help each other to achieve the goal to mainstream rights of persons with mental or intellectual disabilities, and also to integrate mental well-being of people into development priorities. Thank you very much for joining us.
Thank you very much, Dr. Izutu, and thank you so much for spending a lot of time with us this morning. But we look forward to seeing you in 3 more events. Thank you.